Dear colleagues, my name is Marian Fanica. It's a pleasure to have here Professor Dr. Erick Souza. Welcome here in Poiana Brașov.
Thank you very much, Marian. It's my pleasure to be here.
You'll speak a lot about endodontics. You'll speak about apical limit. What is the apical limit? And I want, in the first place, to define that, because I learned in the school there is a difference between the radiological apex. It's a limit between the histological and the anatomical one. You said you'll redefine it. Please, give us some hints.
Okay. Well, first, it's a pleasure to be here to talk with you about this topic, and I think it's a very important topic, even though it has been rediscussed in endodontics for many years or decades, I would say, but it still is important because it's written in the endodontist DNA that the apical limit is something very important to reach success. And in my presentation, I want especially to discuss that all the points that we are taking in consideration for defining a good apical limit may be wrong. During the history of endodontics, we have been taking the anatomical part of the root canal, the radiological aspects, and the histological findings as the main reasons to decide a good apical limit for the preparation and for the obturation. And we really think that these basic knowledge will influence the success rate of the treatment. And in my lecture, I want to address the fact that most of those research are not really reliable at all because of many problems in the research itself. And we also talk about the differences that we see in the literature may not be reliable. So what I want to do with the audience is to make them thinking to reconsider all the aspects that drive them to define a apical limit, for instance, for vital cases or for necrotic cases.
Should be the same, because I learned that you should stay around 0.5 millimeters on vital too. You should reach 0 millimeters. Basically, you should clean up to the apex, everything.
This is a basic knowledge.
Yeah, this is the first thing that you learn.
It's based on anatomical, histological, and radiographic findings, as I told you. But what I want to say is that all those literature, they may be biased. So being biased, they make you biased in your decision as well.
That's true.
So what I want to define, especially in the end of the lecture, I like to address that I define my apical limit based on two points that for me are very important. What is predictable from the technical point of view, what we have in hands with our instruments, and what is plausible from the biological point of view. So from the biological point of view, it's plausible to go as close as possible to the foramen because you may have your foramen infected. So you have to drive your endodontics to this point, otherwise you may lose some bacteria or inflamed tissue that can be a source for bacteria. So it's very plausible that if you go to the foramen, you can address more area of the root canal that may be infected.
At least sounds logical.
It sounds very logical. And of course, we are always afraid of being at the foramen because, we are afraid of extrusion of materials, irrigants. And this is something that I will also address in my presentation, how to control this and how we especially in terms of irrigation, we have been afraid of the accidents with sodium hypochlorite, and I will address with some results, clinical results that we have now, to show you that these kind of accidents occur in specific cases where the anatomical apex is reaching the mucosa of the patient. when the apex is inside the bone, you don't get this kind of errors. We have some kind of new results, clinical results that are very interesting to share with people.
Yeah, I thought about that because otherwise you have to exercise a lot of pressure to put a lot of sodium hypochlorite in the bone.
Yes.
Yeah. If you have the root in the contact with the mucosa, then it's quite easy.
Then it's easy.
Or if you have a periodontal pocket.
Yeah.
I will reach now the second question. This is a question from myself, also from my colleagues. For example, we have this case. You have a patient with radiolucency on the radiograph, a periapical lesion, with a tooth that is totally asymptomatic.
Okay.
Yeah? And then you have to make a bridge, a crown on that tooth. What will be the decision? Because sometimes I will explain the patient, this tooth has a problem. On the radiograph, looks like it has an infection. It has a periapical lesion, We should treat that tooth. And the patient will say, okay, I will trust you. I will start to make a retreatment, and then the tooth will become symptomatic. And the patient will say, doctor, what you did here? Because for 10 years I had no problem with this tooth, and now you treat it right. You say that it's perfect, and now it hurts. What you should recommend?
This is a very, very, very good question, and I would say since I found myself as an endodontist, I have been facing this question in my mind, and also I have trying to study this in depth. What I would say to you is that the basic principle in medicine is to treat patients that have disease. If you have a disease, you should be treated. That's the basic principle of medicine at all. But you could say, okay, but this disease is making some hurts to the patient systemically speaking. This is something that we are still...
It's debatable.
It's debatable. There are some evidence that yes, some evidence no. I think the amount of lesions may be something that hurts, but, well, we still don't know. But the basic principle I have in my mind is, if the patient is sick, you should treat it. It's the basic principle. But that's not the problem. For me, the problem is related to making a good diagnosis on the source of the problem. Because you may think, normally we may think that the previous treatment has failed in healing the apical lesion because of we couldn't control the infection. And the basic principle of the endodontic is, if I redo the retreatment and improve control of infection, I may face better results. I may arrive at better results. But what I would say is that in some cases we might be wrong because the source of the infection may not be accessible by the current techniques we have. And this is something that you cannot preview in your diagnosis appointment. So it's very difficult. Sometimes you may have a incomplete fracture that is contaminated in the apical portion, and this is the source of the problem. Or you may have extra radicular biofilm. So if you cannot access that. So if you could have a tool for diagnosing where is the point, where is the problem of or the source of the infection, then we could make a more reliable decision. Okay, maybe here we have to go directly to surgery, or even this root is not treatable anymore with the techniques we have. So better removing it and placing implant for having a more reliable bridge or something like this. So I think our point is not technical anymore, I would say, but much more related to the diagnosis.
We also some graphs with basically the anatomy of the root canal system, and we saw also the rotary files are addressing something like 35-40% all that surface. You have a lot of dentin that is not touched by a mechanical meaning. You have to rely a lot of chemical irrigation, but sometimes you have like a lateral canal that it's obliterated with smear layer that is not accessible to irrigants. So what you're doing in this case.
This is very difficult to decide, isn't it?
We have to rely on the idea that we cannot save every and single tooth on this world. Some teeth are
for the time being. I think that's the it's a failing for our treatment, for endodontics in general, I would say, that we are not able to diagnose which are the cases we are not able to treat. Because I always think from the point of view of the patient. Sometimes you apply a treatment to a patient, and 3-4 years later, you realize that you could not heal the apical lesion. And for the patient, it's quite annoying to pay for a treatment that's not really inexpensive in most of the countries, especially with a good professional. And at the end, you are still sick.
Yeah,
it's quite
especially when you have like a prosthodontics, you have a crown over there.
Yes, and you have to keep on making investments on saving this tooth. So it's something that we should focus more in endodontics, not only from the clinical point of view, but especially from the scientific point of view. You mentioned something very interesting about the percentage of root canal walls that we are able to touch. And this is quite interesting, because if you address the literature nowadays, you're going to see that almost nearly all systems in the market are unable to 100% reach the root canals. So how come we can reach success in many cases, even don't touching all the root canals? So it's kind of this is a kind of metrics, a kind of surrogate in endodontics, that we still don't know which is the limit that is, well, if we touch this limit, then we have success. If we don't, and then if we don't touch, you have failing. This is something that we still don't understand, and we should improve in terms of understanding how those surrogates really impact the result of the endodontic treatment.
I want to talk a little bit now about your protocol of doing endodontics. About the rotary files that you are using. You are using like a manual sequence of files. You are using rotary. You are still using calcium hydroxide, because it's a controversial topic in the last period. I learned that calcium hydroxide it's like magic for endodontics. You just place it there, it will do its things. Everything will get better. We see the literature in the last period. Calcium hydroxide is not doing a lot. You are still using, like, I don't know, miracle substances?
No, actually, my protocol is based on access, drilling, and filling. That's my base.
So keep it simple.
Yeah, keep it simple, direct, and doing what the techniques allow me to do. That's what I think about an endodontic protocol nowadays. So I just, as a curiosity, I was formed in a school in Brazil that is maybe the most famous in the world school that is teaching the use of calcium hydroxide for treating teeth with apical lesions. So I have this on my DNA, my background. And for me, it was very difficult to realize, by reading the literature and by getting my own results, my own control results in my office, that calcium hydroxide is more as a surrogate than not only calcium hydroxide, but all those miracle substances and chemicals that we are used to think, and different schools around the world are trying to make the mind of their students to use as a miracle substance that can drive your treatment to more safe results. But actually, when you realize from the literature, especially the literature with clinical trials, you see that adding this step to your root canal treatment doesn't improve the rate of success in your cases. So what I think nowadays is you have to do an access that is as small as practicable, not those ninja axes. I don't like it very much.
Sometimes you can miss a lot of anatomy.
Yeah, you can not only miss. Yeah, it's not only the case that you can miss, but it's of course you can miss. But I think when you are drilling so small axes, it takes so much time, and the learning curve, it's so long and strong that I think it doesn't worth for the amount of dentin you save.
But they are good for Facebook.
For sure, no, there's no doubt. But So I think you have to do it small, to be practical, to find the root canals. I am now a user of the reciprocation motion. I think it really has changed endodontics in many ways, and I'm majorly user of the reciproc motion. I go to the foramen, and I try to make foramen size 35, 40, most of the cases, especially infected cases, and then I fill it. Yeah. That's what I do.
For you, it's mostly single visit?
Mostly, the majority of the cases are single visit.
You are still placing calcium hydroxide, for example, if you have a case where you cannot obtain a dry canal, when you don't have time, maybe you have a patient that is coming in an emergency, you are still placing something like this, or?
No, I do it. I do it for keeping the space a little bit, feel it, to avoid growing of new bacteria or something like this, or leakage, I would say. So I put it just for the second appointment, but not with not expecting that I will get more healing, or it's not a basic protocol. So the majority of time I finish my cases on single appointment. I work with four-handed dentistry with very efficient assistant, so I keep my eye on the root all the time. So I think we have very fast appointments. So I normally try to do single appointments. Yes, that's it.
We've seen in the last years, in the last period, some amazing improvement in the nickel titanium allies. For example, in the last files, last generation that we have, it's really good. It's uncomparable to the one that we have 10 years ago. We'll have in the future also advances, but are we at the point where we can replace that this technology? For example, can we have, for example, lasers? I've been at the endodontics congress and someone presented like laser is the future. You just put it inside the root canal and it will heal. We'll still rely on the future on the rotary, on the mechanical meaning, or we'll have something like a miracle substance.
No, I think for many years we still are going to rely on instruments to get us to the apex. I think there's no way to escape. At least I don't see something that will change it. I would say massively, epidemiologically within general practitioners and even endodontists around the world to use such technologies for root canal treatment, because our endodontic DNA is based on enlarging the root canal. So I remember when the SAF technology was released, it was quite difficult to make people think on SAF instrumentation as a good instrumentation itself, because it was not removing dentin from the root canal.
It was conserving.
Yes, it was conserving dentin, and most of the dentists were not confident about that.
It's like I'm not doing
anything inside the root canal, even though it was the instrument that was developed that probably touched more root canals in the history of endodontics. And you see that how those things are complicated in our specialty. So I think we are still going to rely on instruments, and these advancements, these new advancements in the technology for developing the nickel titanium are really interesting, especially for more difficult cases. And this new technology on the thermal treatment of the files are very interesting. It opened a window of treatment in those cases that you need to pre-bend the nickel titanium file. So I think this is quite interesting innovation for us, based on the idea that we are still going to be practicing endodontics based on enlarging the root canal with a file.
So tomorrow you will not going to throw all the files and take a laser and just put it on the
let's have the foot on the ground. I think that's
it's true that we are enlarging the root canal just to make enough room for the irrigants to act, or we are enlarging the root canal in a mechanical way to remove infected dentin. Because in my mind, all the time I'm enlarging the root canal with the idea that I will remove a part of the infected dentin, but I will make enough room for the sodium hypochlorite, EDTA, citric acid, no matter what you are using in a combination to address also smear layer and the bacteria. What is in your conception?
In my conception, it's a little bit both of those two ideas. First, to remove as much infected dentin it's practicable. It's that you can expect an instrument that is rotating or reciprocating inside the root canal can do in a oval-shaped root canal with a instrument that is basically round. Yeah. So we should not expect too much from this point, but what I think that is important enlarging the apical portion is to provide better irrigation. I think irrigation is something that we are skipping a lot in our practice. And tomorrow in my lecture, I will address this point because most of the people I know, especially students and recently graduated dentists, they are afraid of irrigating close to the apex, more or less like the Dracula here is afraid with the crucifix. So I would say this is the point that we are educationally speaking, and now I speak as a professor. I see most of the people afraid of irrigating at the apical portion, and that's why I will comment again the results of the study we are just releasing. It's very interesting for dentists to show that some cases you can expect an accident and you can prevent an accident. But in the majority of cases, you can safely drive your irrigation to the apical portion and get the best from the disinfection ability of the sodium hypochlorite at the apex, which is our difficult part to treat. So I think tomorrow maybe people can be more confident on irrigating close to the apex.
Yeah, I will waiting for that.
Yeah.
Because myself, after seeing some picture, also on Facebook with sodium hypochlorite accident, with basically half a face necrosis or something like this, you start to think a little bit more about the pressure that you are applying. And basically some basic fact like moving all the time the needle inside the root canal, not blocking, it will prevent the sodium hypochlorite accidents.
Yeah, for sure.
Are you agitating with ultrasound? Are you using dedicated device, for example, to activate the sodium hypochlorite?
I do, mainly because of the debris.
Yes.
The debris, and also to improve the action of the sodium hypochlorite into the tissue dissolution. Because tissue dissolution, the pulp tissue dissolution by sodium hypochlorite is the part of the sodium hypochlorite that takes more time to get done. So we have some studies that show that you have something good in terms of pulp removal, of the pulp dissolution, in between 15 minutes and 30 minutes of contact of sodium hypochlorite, which is, clinically speaking, it's a lot of time.
Yeah. No one will wait that much.
Yeah, yes, and that's a point. So if you need 30 minutes to get to reach a point of dissolution, that's not the ideal point, but it's the best point that you can reach. I think we should use something to improve this ability to remove those kind of tissue. So that's why I normally use, still keep on using ultrasonics.
It's a passive way?
A passive way, yes. A passive way with a thin file, kind of 1 minute, and then I think it's ready for obturation. But it's quite annoying that, imagine a case that you just do all this protocol, you keep 1 minute, and then you think that everything is okay, and then you feel. But if you were to know that more 30 seconds, you could remove the biofilm that will keep, the infection. So it's quite annoying that for me, it hurts me as a professional.
In the future that will let you know how much you have to irrigate the root canal.
I think the industry should place more efforts on diagnosing the biofilm.
Yeah, I'm totally agree with that.
If we develop a device, and we are not far from that, because nowadays we have the confocal technology that can be adapted Of course, some investment is needed to make it very thin to introduce inside the root canal so that you can map in real time if you still have biofilm or not. This is quite good for us because imagine if you have a case in which you use a single file, just 5 ml of irrigation, and then afterwards you place a device and you see that everything is clean, no biofilm at all. Why are you going to still keeping on irrigating with sodium hypochlorite, which is damaging the dentin in a long term? So why you are going to do that if you are already there at the control of the infection? Yes. So what matters for us is to control the infection. The point is, how do we know if you have controlled it or not? That's the question we should address as researchers, as clinicians, as professors. I always say to my students when they call me, Professor, do you think I am disinfected here and I can obturate?
How can I tell you that?
Yeah, that's and I feel myself very arrogant if I say, yes, you are disinfected, you have a good level of disinfection.
No, you still have one bacteria there. He will start multiply.
You can understand that. It's quite frustrating that we don't have a kind of technology to give us more detailed information about the infection level. I think that's the new day for endodontics. That is the paradigm shift that maybe will change endodontics in the future.
That's the next big thing in endodontics. Okay.
That's what I expected you at least.
I will ask you now a simple question. What is your procedure? Let's take, for example, an upper incisor. It's from a clinical point of view, without the bacteria, it doesn't have a pulpitis, it's a vital tooth. You have to make a root canal treatment. I don't know the reason why we will make a root canal treatment on the vital tooth that it's perfectly sane. What is your protocol? From the burrs, are you using, for example, spherical burrs for the access? Are you using like a pilot file, a manual one? Are you using a reciprocated one? What is your protocol?
My protocol is based on, of course, isolation for all
This is
cases.
the first thing, or you are making the cavity before?
No, I do isolation always.
This is the first thing?
Yeah, the first thing. I normally I like to work on a more, confined area, clean area.
And focused.
And focus it. So, of course, you have to take in consideration the axis of the root in order to the access to avoid perforation and things like this. But I'm quite used to do that. And I also teach my students to do that, to isolate first and then open with normal burrs. I normally use the spherical burrs. No issues on that. I remove the most as possible roof of the pulp chamber. Only remaining some parts that I can control with an ultrasonic tip or something like this.
So the fine details you'll address with an ultrasound?
Normally I try to avoid big, removal of the roots or extra removes of the roof of the pulp chamber or the walls of the pulp chamber. Normally explore with a 10 file. Okay.
Just with the manual?
With the manual for an exploration. Okay. In order to check whether the root canal is there's a patency in the root canal for accessing with the file. And as I told you, I am a reciprocation user, so I normally go to the reciproc files.
No orifice opener at this point?
No,
just the file.
That I skipped this step by step.
So no gates, no orifice opener, just the file.
No. Okay. I skip it from my life. This step-by-step root canal preparation. I think the R files, the R family, 25, 40, and 50, they do the job. That's what is important for us. Do the job. What's the job? Enlarge the root canal, make some taper, and arrive at the working length without the risk of a minimal or with a minimal risk of fracturing the file. That's what is important.
It happened to you to fracture? When was the last time?
It happened a lot in the past before reciprocation.
I feel you.
But after reciprocation, I almost it's a very hair episode in my office. So now I work much more relaxed than I was working in the past. Even though in the past I was trying to control as much as possible the use of the instruments, the deformation on the instruments, but this is quite difficult. So nowadays my protocol is very simple, including my communication with my assistant is also very simple because she just have to know the reciproc files, and then she give me one of the three,
it's
and then
simple.
it's
You
very
don't have,
simple,
like,
very
10
direct. Yes, you don't
different-
have to address many instruments, and you don't have to do this step-by-step root canal preparation. Even if we are speaking about a upper incisor, as you told, or a more complex molar, I normally do this. I explore the root canal with a K file, and in Brazil we teach people the 10K file rule. This rule is, if the 10K file was able to reach a length, your R25 will be able to do it. That's something that we are teaching, we are doing, and we have also many publications in vitro and in vivo showing the ability of this system to reach the apical portion without a glide path in more than 95% of the cases, with minimum level of fracture of 0.2% of fractures. So this is something that is really, really, really good for our daily basic practice.
So that's a big improvement in
for me
in
it was something that made us skip from the more of the same that we were seeing in the last almost 20 years. Because if you have a close look to the history of endodontics, in the last 20 or 15 years, most of the thinkers, most of the researchers and the file designers, they were thinking on preventing fracture or removing fracture of the file from our agenda by changing the design of the instrument. And the reciprocation movement was the first significant changing that was not in the design of the instrument itself, but in the movement, so in the motion. So this was very significant because it, in fact, has lowered the risk of fracture and has improved the ability to explore the root canal.
You are entering inside the root canal in the presence of EDTA, where you are using, for example, like cream, like EDTA cream or lubrication, any
None
type
of
of
them.
lubrication.
None of them. I'm a sodium hypochlorite user. I don't use EDTA. I also remove EDTA from my protocol because it's the same as the calcium hydroxide. If you go to the literature, you're going to see many works addressing which is better for removing smear layer from the root canal. But there is no single proof that is the maintenance of smear layer in the root canal will lower your success rate. This is based on plausibility. We have plausibility that if you remove smear layer, you may clean better inside the tubules, and you may have more sealer inside the tubules. But is this really improving the success rate of endodontics? This is something we don't know. So smear layer is another surrogate in endodontics. We think that it's important based on many studies, but at the end it may be not, or at least we still don't know if it is important. So because we don't know if it is important or not, I'm not putting one more step in my treatment. So I only use sodium hypochlorite. That's my
Then
decision.
dry the canal.
Dry the canal.
Obturation with continuous wave, or you single cone?
I
for
use
example?
mostly single cone.
Okay.
I am a single cone. I prefer not to compact the gutta percha.
So you are using the simple way of doing a root canal treatment.
Totally.
And in your opinion, your practice is the most predictable way of doing endodontics.
For sure. No, I have no doubt on that. I have skipped all these complicated issues from my list of practice. In the last 15 years, I was skipping one after the other. Yeah. And I just realized now that was the best decision I have made, because I still have predictable technical results. I do good endodontics in technical terms, and I see a lot of healings in my practice as well. I see cases that don't heal, and that's my how I would say my Yeah, that is something that makes me think where is the point we are not seeing
Something's
yet.
happened there.
Yeah.
We should address that thing.
Yeah. And you know what is interesting? If I show right now to you a case of mine that has failed, and I show to you and you ask me, what was your protocol? And I say, it was this, and this. And you say, oh, maybe if you had used the calcium hydroxide.
Maybe you'll do it better.
Or EDTA. I always say to my students, if you are rich enough, it's not the case of Brazilians, maybe in Romania.
We are terribly rich.
But in Brazil, we cannot reach this level. But if you are rich enough, and I'm not saying that you are a dentist, but a rich guy, if you are rich enough to buy all the stuff meant for infection control, and if you have all the devices that are now developed or that were developed in the history of endodontics to controlling the infection, you never get ready for filling the root canal, man.
That's true.
Isn't it?
Maybe we will dissolve the root canal.
Yeah.
You'll have nothing to treat there.
It's amazing because we have a lot of devices, lot of ideas, lot of protocols meant for. And if we start discussing why I failed, you always have something that I haven't used. You haven't used that, so maybe you got failed.
That's in
because of
my
this.
practice. Sometimes when a case fails, I will start to ask, maybe that case failed because I didn't use that.
Yeah.
Maybe because I didn't stay 5 minutes longer to irrigate. I'm sure right now that no matter what I will do to that, it will fail in the end. Maybe the biofilm was too wait to develop. Maybe on the outside of the root, I had nothing to
for sure
to address that issue.
Yes, for sure.
So
for sure.
we will see a lot of smart topics. And you'll address a lot of problems, a lot of questions that we have in general, we dentists have, especially the endodontist. Because here we are working in blind. You are going inside the root canal. You don't see all the dentinal tubules. You can see on the electronic microscope. You cannot see it by yourself. You just can't imagine what is there. We will be there. All our attention will be on your presentation. Thank you for being with us here. Thank you.
It was my pleasure.
It was my pleasure.
Okay. Thank you.
Bye-bye.
Bye.